name is Caitriona Muller. I am an expert with the Association of European Border Regions, and my role currently is to work on implementation of some of the B Solutions project case studies. B Solutions is an initiative of DG Regio, which is creating a body of evidence for solutions to administrative and legal obstacles to cross-border collaboration across Europe. We currently have calls open for applications. So if anyone is in a border region and interested in applying to B Solutions for an expert case study support to help to progress a particular obstacle, please get in touch with us, and we'd be very happy to discuss with you. The other thing that I did last year with AEBR was led a study on cross-border patient mobility in selected EU regions, which was commissioned by DG Santé. And it was commissioned in the context of the review of the European Commission's own evaluation of the Cross-Border Healthcare Directive. So I'm going to just share my screen, and Christopher, as you can probably hear, I'm originating from the Northern Peripheries eligible area myself, and I just wanted to say as well that I'm actually just back from Ostrobothnia, where AEBR had our executive committee meeting. So we actually had our committee meeting last Friday as we crossed the maritime border on the Aurora ferry from Vasa to Umeå. So we have heard very, very fresh from a lot of our members in that region, not only about the kind of innovation that's going on in healthcare, but also then, of course, the impact that the recent months have had in terms of our colleagues in Karelia. So I just wanted to say hello, and yeah, I look forward to hearing more about the kind of healthcare innovation that's going on up there, because some of it is really relevant. So thanks. Okay, I'm going to share my screen now. If you can just bear with me. So, can you see my screen?
Yes.
Yes, we can.
But not the, I mean, not in the full, you know, we can see also the slides.
No,
Yeah.
no, it's perfect. Yeah.
Yeah.
Oh,
that's
that was my question. Can you see my slides? You can. Great. Okay. I only have 10 minutes to speak, so I'm going to try and focus on what I think the important points are for this audience today, which is clearly, from what I can see on Mentimeter, that there's a little bit of a window of opportunity for people to think about exactly what would be useful to support in terms of Interreg health cooperation. And the kind of areas of knowledge that I'm going to draw on are firstly the AEBR DG Santé study, which is an extensive long study. It has 4 case studies within it of different cross-border territories, and that's available on AEBR's website and on the DG Santé website. The other area I'll draw on are some of the AEBR DG Regio B Solutions case studies, which focused on issues linked with patient mobility and some issues with actual health system and healthcare collaboration on borders. I have 3 decades of hands-on experience in managing and brokering cross-border territorial cooperation, including in Ireland, Northern Ireland, where I continue to have input. And may I say, our land border cooperation is very deep and very stable at the moment. It's an important message to give. I've also spent 1 full decade working within the health service, including the cross-border partnership of the health services in Ireland, Northern Ireland, and then also within the National Health Service in the UK, working on actual improvement and system reform, particularly towards an earlier interventional system overall, and preventative approaches to health. So that, with direct experience of managing Interreg programs, and also looking at some of the learning that we pulled out of the DG Santé study as regards health in border regions. We conducted the study during COVID-19, during the pandemic. It was all done virtually, which was quite fascinating to be talking to people about patient mobility in real time, as everyone that we were speaking to was dealing with different border closures and changing restrictions every week. So it was a really fascinating and very intensive period to be doing this kind of research with people across Europe. So in terms of the learning from COVID, and the reason I'm putting COVID first is that we're all probably just still in that very high functioning shock of having had a major shock to our system. And of course, we have a second one now with the Russian invasion of Ukraine. But it's important to take stock of the COVID-19 pandemic. I mean, this time 100 years ago, Europe was coming out of another pandemic. And so this is we are just after the next big pandemic since the 1920s. It's very important that we think now about how we can embed some of the learning from this pandemic, because I think it's going to not be too long before we're facing something similar again. And there's particular learning about what COVID told us about the health of our health systems in border areas, and perhaps told us about how we need to develop resilience across the European Union for the future. So obviously we had things like border closures, which happened in some cases in a blanket way, which meant there was no exception for emergency patient transfers. So we had some cases of patients being transferred from one ambulance to another in the forecourt of a filling station at a border. We had some regions that couldn't effectively use hospital beds that were just across the border because there was no protocol in place for emergency bed sharing. There's been a lot of learning embedded and in process, particularly places like Luxembourg and Grand Est in France, who really took these kind of experiences seriously, and halfway through the pandemic said, right, politically, we are now turning our face to actually do something about this so that we have this better collaboration, so that we can avail of the proximity principle for care, rather than having patients transferred hundreds of miles within a particular member state, because that's the nearest nationally owned available bed. So there was stuff like that that was very important for health systems on borders to be able to look at, to develop their own resilience. We also had cross-border healthcare workers who couldn't get to work. If you can't get to work as a cross-border healthcare worker, the place where you work cannot operate a safe level of service because it doesn't have safe levels of staffing. So therefore you have to close beds, or you have to close wards, and so on and so on. So there's a knock-on effect of all of this kind of unprepared border closure on health systems. And that was very, very acutely felt, particularly in places like Luxembourg, which depends, 40% of the Luxembourg healthcare workforce comes from across the border. We know also that local and regional government and municipalities were crucial during the pandemic as the structures closest to citizens in providing healthcare guidance, in communicating healthcare, sort of public health restrictions, and in generally responding to the very, very basic needs of their citizens in the middle of the pandemic, particularly very vulnerable citizens who needed additional social supports in order to survive. I think the big message from AEBR is that 40% of European Union citizens live in a border region. If we are serious as a European Union about a right to health, we must try and manifest that and express that as an element of cohesion and as an element of integration, of resilience and recovery. We know what the tools need to be. Interreg is a crucial enabler of this kind of collaboration, particularly in its initial stages. It allows systems to get things off the ground and to develop new ways of doing things, provided that they then embed those into their normal business. Then it is a huge asset. And we also know that multi-level governance at a territorial level is hugely important for the health of border populations, but also for the effective functioning of healthcare systems on borders. So place-based approaches to health and healthcare cooperation, health systems working in partnership with civic leadership structures, particularly at borders where there is capacity through a lot of border regions, a lot of our members, there's huge capacity there to support healthcare systems in doing new things on borders. So I'm hoping that Interreg is one of those things that will help to support that. The challenges that we found from the study, obviously, I don't need to tell anyone here that cooperating on healthcare across borders is complex and challenging. We found with our study, which focused a lot on data mapping and a lot on the nature of data capture on cross-border patient mobility, ultimately, you cannot do good service planning or service innovation, whether it's cross-border or not cross-border. You cannot do it without good data. You cannot do it without evidence, and you should not be doing it if it's not an evidence-based approach. So there's a need for better data. There's also then, on top of that, what we found was that there is still some way to go before full healthcare systems will maybe have an opportunity to understand the benefits of innovative approaches to service delivery in border regions. It can really be a way of releasing potential of the full value of a healthcare system rather than a drain on resources. What we still see is institutional should we say institutional apprehension about cooperating across the border because it might mean a loss of resources. In fact, if you can use your resources as a lever, you can lever in added value. And I know where there have been cross-border shared health services commissioned, for example, in my own city. I'm speaking to you from Derry, just on the Northern Ireland-Irish border. And we now have a cancer centre which was commissioned on a cross-border model of feasibility. It would not have been invested in by either government on its own for one side of the border, but as a cross-border facility, it has stood up and each government funds at 50%. So there's a lot of stuff like that that we found that there's opportunity to demonstrate possibility, particularly to member state governments, about what they can do on their borders. And of course, the Commission has recognised that border regions are now laboratories of European integration. And what does European integration mean in health? We know that from the research also that citizens need better information on their patient rights as European citizens, and that this needs to be proactively provided. There are some very good case examples. For example, in Euregio Maas-Rijn, they have these border information points which are citizen orientated. Particularly vulnerable citizens with disabilities need particular supports around information and access to the same kind of mobility choices in border areas as other people. So we find quite a lot of issues like that. Again, complexity is in the report. You're welcome to go and have a look at it, and I'd be quite happy to answer any questions from anyone who wants to correspond on it. We also know that the outstanding challenges that are still there in cross-border healthcare cooperation, which have real meaningful outcomes for people on the ground if they're not solved, are emergency care cooperation, healthcare workforce planning, particularly where you have a cross-border workforce, cross-border regional healthcare workforce. We still have outstanding issues like administrative delays in the recognition of qualifications. We still have issues around taxation and social insurance issues, which are usually down to the interpretation of one particular institution as to how something should work. We need really to take what I might call a front office based approach to frontier workers in healthcare, rather than, you know, the system meeting its own needs and then the healthcare worker or the citizen having to navigate those different boundaries themselves in order to do something very simple like sort out their tax and social insurance. We do also have some inconsistencies across different territories in relation to what might be reimbursable as a healthcare expense for a patient wishing to travel across the border. Now, that in itself is at the discretion of healthcare insurers. But if you're a healthcare system and you want, for example, to do something really ambitious, like do some really innovative collaboration on elective care post-COVID, because you have very long waiting lists, and working with your neighbour together, you can share resources and you can help to impact each other's waiting lists as healthcare operators, then how patients are reimbursed for their care starts to matter as a quantum issue. So these issues are all there. They're all solvable. There was nothing that we came across in that report that couldn't be solved by good collaboration and interagency working at the borders with the right resources attached to it, which is the good news. The other thing we are also very aware of from the research is that, and because we were focusing on planned care in the research, because the directive is for planned care rather than emergency care, Europe is facing a crisis in elective care. That is one of the learnings and one of the issues coming out of the pandemic. We have massive waiting lists everywhere. We also have mechanisms that are available to us across the European Union and from the European Union that can help us to tackle those things if we configure those assets and resources in a way that focuses on territories and particularly cross-border territories. This kind of approach will ultimately reduce the burden of cost on all national healthcare systems, and that's a message that I think is hugely important for the member states to appreciate, and also for the member states to realise that border regions and healthcare operators and the civic authorities in border regions can be very, very good partners to the member states in really deepening that idea of active subsidiarity beneath the level of the member states. In terms of our existing assets that we have as a European Union, we already have the Cross-Border Healthcare Directive. We have the Social Security regulations. We have lots and lots of bilateral agreements between insurers. For example, the ESM card, which was a famous one in Maas-Rijn, the Zorg Pass. There are all sorts of bilateral between insurers that allow for patients to move across borders. We also have member state bilaterals, for example, the Ost-Belgien-Regelung, which allows people from Ost-Belgien to access care in Germany. These are the existing legal and reimbursement mechanisms that exist. They do not need to be reinvented. The other assets that we have, which we found through the research, are also absolutely essential for cross-border patient mobility and for giving meaning to patient rights in border regions, are that we have institutional partnerships in border regions. We have all of the Euregios, we have all of the municipalities across every border, internally and on the external borders of our European Union, which are working in partnership to develop and support the well-being of their population, the growth of their region, and the overall health of their region. These are assets for health and healthcare cooperation. We have effective and appropriate multi-level governance solutions with the right partners involved. We also have things like the EGTC, which is a European legal mechanism that can be used by a grouping of institutions who wish to actually achieve functionality in the provision or the performance of a cross-border task or program or function. We also have the Interreg program, which is an asset. So these are the people that this is the conversation we're having today, is what can Interreg do as part of that collection of assets that exists across the EU? How can we reconfigure our assets in a way that actually really takes account of the fact that we're just out of a pandemic? We have the biggest mass movement of people in Europe since the end of the Second World War. What does that mean for how we do health at borders? So we also have some governance obstacles. Usually those are at the level of sub-institutional level. And again, with the right kinds of partnerships on borders, people can work through those things together. They can use the B Solutions project from AEBR if they wish, but they can also find ways of working around things. Partnership and relationships are absolutely at the core of all of this. In terms of the actual kinds of opportunities, I think that Interreg should be looking at, frankly, the idea of shared services in border regions between healthcare operators. This adds value to healthcare systems of member states. It also improves the health status of citizens in border regions. So if you have an expert orthopedic surgeon who is on one side of the border and half an hour away across the border, you have a waiting list of people, like 2,000, 3,000 people who've been waiting for a knee replacement and who might have to travel 800 miles in the other direction to have that by the time their turn comes. Can your health system talk to the health system that has the orthopedic surgeon half an hour up the road? And could we find ways of actually allowing those people to have an operation closer to home with less peri-care costs? And can we also then see what the impact on the health system is of those people not needing painkillers for the next 3 years while they're waiting for their operation? So there's some very, very logical thinking into which the border solutions fit. We need to pay attention to the front office around patient and citizens information on their healthcare entitlements, on their related social security and healthcare insurance entitlements. There is not enough information available across the European territory for citizens on healthcare mobility. And that needs to change. So that's the front office. You need to pay attention to the back office, building capacity for institutional collaboration, giving institutions the space outside of very, very busy service lives where they're literally running health services as a matter of life and death every day. They need the space and the resources to be able to develop these kind of partnerships, to do their strategic planning. So pay attention to the back office as you decide what to support with Interreg as well. Look at workforce development issues, look at healthcare workforce mobility, look at recognition of qualifications, and look at virtual healthcare solutions. Look at how you can address language borders in the provision of healthcare. There's some very good practice in Gmünd Hospital in Austria, which serves a cross-border catchment in Czechia and Slovakia. Look at, again, shared services. Look at models like Verdania look at the Northwest Cross-Border Cancer Services in Ireland, Northern Ireland. Also, one of the issues that Euregio Mass Rhine are very keen on is looking at how border territories can develop shared approaches to the procurement of high-cost clinical equipment, particularly, for example, diagnostics. So if you have a border territory that has a very high cost, very high function MRI scanner, can you share that service across the border so that people can have their diagnostics done more quickly? Can you develop joint approaches to procurement between two health systems so that you're not duplicating each other's costs, and so that you can then provide services to a cross-border patient catchment? Think about interventions that are aimed at addressing health inequalities in border regions, particularly support interventions that are about clinical collaboration to support gender-specific medicine, to support women's medicine, to support prevention and early intervention, so to support people, to empowering people to look after their own health in the community, and all of those kind of things that have a little bit of a territorial focus, and in some cases in cross-border territories an epidemiological focus, and in some cross-border territories you will have the prevalence of long-term conditions precisely because of socioeconomic disadvantage. So these kind of approaches really matter in border regions for health outcomes. Also look at supporting cross-border territorial approaches to data collection on patient mobility, but on other aspects of healthcare system operation that might be useful for the planning of shared services across borders and shared infrastructure. Look at how your spatial planning processes in your regions, and you're all Interreg people, so you will have a sense of what else is going on in terms of Interreg priorities. But if you've got work going on territorial cooperation that involves data, spatial data, are they including healthcare data? Are they including population health data in that? Let's look at how we can integrate health into the whole smart regions agenda and the spatial planning agenda across Europe, because that's where it needs to be. I'm going to leave you with one slide, which is really at the end of the day, and this is, I think, particularly important for people who are perhaps managing healthcare programs, but are not necessarily within the healthcare sector, and who are not necessarily specialists in cross-border health, but are handling a wider territorial cooperation program. Ultimately, the bottom line with any kind of healthcare collaboration supported under Interreg really ought to be, does it actually contribute to addressing quality of health outcomes for people in border regions? And I suppose I would ask another question is equality of health outcomes across our territories an ultimate resilience goal for the European Union? Because we've 40% of our population in border regions. 40% of our population is a big percentage. We've seen from the pandemic what happens when population is either unable to work or is ill, or we also know that the people who suffered most and who took most the larger than their fair share of fatalities and mortality during the pandemic were people who had a lower health status before the pandemic. So we really need to learn from that there is a social equality issue here, which translates into health equality, and which can then translate into economic equality if we so choose to facilitate that. Prevention and early intervention across the whole system, always good to fund, particularly in border regions. Focus on mental and physical health outcomes. Look at community health promotion infrastructure. So are communities getting involved in helping to promote health and facilitating people to live in healthy places? The individual as their own health, their own expert in their own health. So empowering people to understand their health, empowering people how to stay well. Life cycles, supporting 0 to 5 early years. Again, Nordic countries are very good at this. We have a lot to learn from them. Infant mental health and maternal mental health. Support these. Why? Because there is direct evidence that if you don't, you have huge prevalence of multiple chronic conditions later in life. So those issues are all about investing in the future and in the most efficient use of future healthcare resources, if that's the argument that you prefer. Aging well. We have an aging society. We need to promote well-being and prevent frailty. We need to look at a very holistic model of well-being that is completely, holistic around the individual. So what does someone need to prevent their own frailty? And it's not just physical supports, it's social and emotional and cultural, and it's family, it's community, it's creativity, it's that spiritual well-being that people need. Women's medicine, I'm going to say this, part of our research also focused and found that there was a lot more that can be done in border regions around multidisciplinary collaboration for women's health. Women's health outcomes are generally lower in border regions, again, just because of the sometimes to do with approaches to medicine that are not necessarily tailored to women's bodies. So there's an opportunity for collaboration. Professor Angela Maas is in the Netherlands, is a border clinician. She's very, very good on this stuff. Read her book called A Woman's Heart if you really want to understand about women's medicine. And she's heavily involved in some trans-European clinical collaboration. It's very important to involve clinicians in research and innovation for health, because if you have it tailored in terms of the clinical evidence on what works for patients, then you're more likely to get it right. Health and well-being for people with disabilities and people with rare diseases and complex needs. Those categories don't all overlap, but what we did find was, again, that the particular needs of people with disabilities in border regions need attention in terms of providing them with equity of access to health outcomes, not just treatment, but actual overall quality of life and well-being. It's also important to think about, if you're talking about the health status of a border population, it's important to think about how you train and retain doctors and healthcare professionals in border regions. And Christopher, I've heard very recently, again last week, about some really innovative virtual working that's being done up around Umeå in Sweden, particularly with care in the community and looking at very innovative ways of using a limited healthcare workforce. You know, over large territories, that long distances, rural areas. So this is all possible. And when you're talking about e-health, e-health is one of the biggest terms that gets bandied around all the time. Understand what it means in the context of what is it doing for patient outcomes, what is the benefit to the patient and to the citizen, what is the end point for the innovation, is the innovation going to be implemented, when will it actually be put into operation? And so it's very important to understand the pipeline of innovation and understand that the pipeline of innovation really needs to be orientated towards ultimately better population health outcomes. And if you do that, you can't go wrong. And so those are the kind of principles I would say to you as anyone, as people who are involved in influencing what happens with Interreg. This final slide is essentially, that's your checklist. And if things can fit into that, then you're going in the right direction. So sometimes it can be a bit daunting to understand exactly what systems need, but I'm hoping that what I've said has been of use. I know I've gone on a little bit longer than planned, but I do hope that it has been of interest, and I'm very happy to take any questions. And what I can also do, Mercedes, is I can share the links to the DG Santé report for people after this. Maybe I'll get you to email it out to people so that they have it.
Yeah. I mean, I think it has been published in the website, so everybody, while they were registering, they could access. I really think that information you're giving, it's superb in the sense that really you're giving us hints to make, specifically to the cross-border, but I guess maybe Christopher got some notes also for the transnational programs, what to do and be more efficient while drafting the goals. And when I made this comment of data collection, not only data collection to prepare the program, as for example, Florin did, but also requesting data collection, specific data collection in the terms of reference. Because sometimes we are not having the information related to health. And this is exactly, so what we would need is as an output, this data collection.
Yes, and that's actually a very good point, because one of the technical recommendations we made in the study, the study gets really down into the data issue. I just didn't want to bore people with it today, but one of the key points that we made, and we think is very important, is that the people who are the non-data specialists, the people who are actually the planners and decision makers, need to see data as their friend. There is a need for the, shall we say, I mean, I work with spatial planners all the time here in Ireland, Northern Ireland, and we're a community. So we've got, we've got data specialists, we've got geographers, we've got statisticians, and, we just call them the data monkeys, and they call themselves the data monkeys. Okay. So they basically, what we need to do is, in a sense, the data monkeys absolutely need to be in the room, but do not be afraid of the data monkeys, because they are actually just there to help.
Exactly.
But equally, do not scientize and mystify the issue of data. So data being seen as just another component of your overall good business processes. So in the same way as you might be asked for a budget plan for your project, what's your data capture plan? What's your data and performance management plan for the project? And in that way, you're automatically, putting the data piece. It's not the biggest thing in the room, but it's there in the room as it should be. So I think there's something about just, how do you, I suppose, encourage a little shift in the direction of data informed decision making. And if you start to capture stuff, then you can always continue to capture it if you choose to. So I think that would be a great start.